Right. And hopefully you can all see that. Yeah?
Yeah. Good.
Yeah.
Cool. Right. Okay. So, I've said let's talk about breathlessness, because this is about us sort of getting together and sharing some ideas and some experience. But in terms of a bit of an overview of the things I need to talk about, need to understand what we mean by breathlessness, and maybe a little bit of overview of what might cause you to feel breathless, and then sort of finish with what you can do about it, and hopefully give you some other ideas and some new things that you might not have come across before, because there's a wealth of information about breathlessness on the internet, and obviously if you're on this call then you can do the internet, so I'll see if I've got anything extra to add to help you. So I suppose the first question really is breathlessness the same as breathing a bit faster or breathing a bit deeper? And some people say that it is, and some people say, well, no, because if I cycle back from work to get ready to do this talk, which I've just done, I was panting a bit when I got home, but I wouldn't have described myself as breathless, because that was an anticipated reaction to something that happened in my life that I do, and I know my body's response to it. But some people will say that breathlessness is that. It's when they're breathing faster than they'd like to, or deeper than they'd like to. So I suppose breathlessness means different things depending on who you talk to. There's loads of different sort of terms we can use sort of talking around breathlessness. We can talk and try and dress it up in medical jargon, which we love to do because it makes us sound clever. So dyspnea is probably the most common one that you might see in patient sort of letters or descriptions of people. SOB is quite a fun abbreviation, which is not sonophore, but it's shortness of breath. You might see that documented around. Tachypnea is when you breathe fast. Orthopnea is breathlessness when you lie down flat. Apnea is when you stop breathing altogether. There's lots of words for breath, but they've got "nea" in them. And the American Thoracic Society describe it as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. And me being sort of trying to put that in plain English, that means breathlessness means when your breathing doesn't feel right for you. Okay, it's uncomfortable. Okay, so I should really sort of cast a safety net over this talk in that breathlessness can be a reason to call an ambulance. It can be a really important sign that something is seriously wrong. So if you can't get your breath and you can't recover your breath and you're tight in your chest or heavy, and particularly with chest pain or jaw pain, or if you're being sick as well, that can be a sign that you're having a heart attack, or something else is seriously wrong and you need to call an ambulance. In terms of seeing a GP, it's more persistent breathlessness that's not going away, it's not improving. Or if it's new, it's a new experience of breathlessness for you, it's worth getting checked over by the GP. Okay. There are many causes of breathlessness. So the physical ones are the ones that probably would scare people. So things like cancers or asthma attacks or pulmonary emboli, so clots in the lungs. It could be something to do with your heart. So your heart might not be pumping properly, which is what is called a heart failure, when it's just not strong enough to pump enough blood around your body, and not just to your arms and legs, for example, but to your lungs and your brain as well. And that might be because of muscle weakness, or it might be for problems with valves. There's loads of things that can cause that related to the heart and breathlessness. You can have systemic illnesses, so other things wrong with you, so disorders with your hormones or your blood or your circulation, your kidney or liver problems, and there can be problems with your brain or nervous system as well. So things like strokes or tumours or injuries, bleeding, nerve and muscles disorders, and let's not forget pain. A lot of people breathe faster and deeper when they are hurting. I see that a lot in the hospital. So pain can cause you to be breathless. So as well as the physical, there's the emotional and the psychological causes of breathlessness. So anxiety is a very common one. It's very, very common when people get uptight or upset, that their breathing gets faster. Can be when you're excited or nervous. So I'm probably breathing a little bit faster than I normally would because I'm sure that my IT is going to go wrong again. I'm cursed like that. And I make a distinction between anxiety and panic, but panic is probably like the extreme end of that kind of scale of anxiety, and it can feel very different, but obviously it tends to look different to anxiety. Panic does. If we had two people and one was anxious and one was panicking, you could probably tell the difference with no medical training. Okay, so things that can be done to help with breathlessness. So the point of going to see a doctor is to see if there's a treatable cause for it. Okay, so we can do things to help the heart function better. We can do things to help you get the best out of your lungs. So things like getting the right inhalers, or the right strength of inhalers, steroids. You'll see oxygen's written there, but I've lined it through. So oxygen for most people does nothing to help with breathlessness. A lot of people think that the reason they feel breathless is because their body's oxygen level is low, and that is not true. The thing that tends to drive the feelings of breathlessness is acidity or carbon dioxide, really. So when I was cycling home very quickly, my muscles were working and using up a bit of oxygen, but they were generating acid and carbon dioxide. And those are the much more powerful stimulators of your breathing. Okay. And oxygen tends not to improve breathlessness. So if I wanted to climb to the top of the 4th floor in the tower block in the hospital, if I used oxygen therapy while I went up the stairs, I'd be just as breathless at the top. Now, that's not to say some people who are on long-term oxygen, who have a prescribed need for oxygen, can have their breathlessness improved by oxygen. So it can do for those people who just in everyday life have low oxygen, but they're the vast minority. So oxygen, it's unlikely to be the reason that you feel breathless. Okay, and there are treatments for reducing pain that we can use sometimes for reducing breathlessness as well. So morphine is a drug that most of you will have heard of. It got a lot of bad press because of a certain Dr. Shipman, but opioids, so morphine can be useful for some people. So even if we can't get your lungs to work better or your heart to work better, we might be able to change the sensation of breathlessness and make it more manageable for you with medical treatment. And there are things that can help calm you down and make you feel less worried or anxious about your breathing. And again, they're not the things that you go to in the first instance, but as a third line medical management strategy, they can be useful. Okay, so if you are breathless and it's bothering you, it's important you have those honest conversations with your healthcare providers. Stopping smoking can make a big difference. If you smoke, quitting can actually improve your breathlessness. Education, so hopefully listening to people like me or reading around the subject and helping you understand what's driving your breathlessness, and experimenting and finding out what works for you. That education can help you manage your breathlessness better. Some people who are overweight, if they lose a bit of weight, their breathing can improve, their breathlessness can improve, which is not a big surprise to know that if you lose some weight, it means you need less muscle power to move you around the place, and there'll be less pressing on your chest, so the work of breathing gets easier. So hopefully breathlessness can improve. Not just about the kilograms or pounds and ounces, but what you eat. So if you have a heart problem, then limiting your salt can improve your breathlessness. Something that's simple in conjunction with your medical treatment. Exercise. I could talk. I'm doing another talk on exercise for you in a couple of weeks. But exercise can make a big difference. So if you get fitter, your body's ability to pump blood to where it's needed and pump waste away from organs as well, that can make a big difference on your breathlessness. And sometimes if there's an obstruction of phlegm or sputum or mucus, if you get rid of that and commit to doing that as a regular part of your routine, that can help with your perceived breathlessness as well. Okay. In terms of other things, so we've got equipment. So something to lean on can make a big difference. So if you're walking along, sometimes using walking stick or a couple of walking sticks, or if you do Nordic walking, you might have come across that. That can make your breathing or breathlessness on exertion easier. And it might help with the mechanical strains around the place. Long-handled shoe horns. So a lot of people will say they get more breathless when they bend forward, or bend down to pick up the post, or bend down to put socks or shoes on. But a simple bit of equipment like a long-handled shoe horn can, make the experience of putting shoes on one, which means it doesn't result in so much breathlessness. Perching stools. So these are sort of high up, sort of like bar stools, really. But you can have them with arms or without arms, and they can go in your bathroom or in your kitchen. So things like chopping veg in the kitchen, or brushing your teeth in the bathroom, you can do while sort of perched on a stool, and that can help with the perceived breathlessness you've got there. Getting up and down off chairs, if you raise the seat, so an extra cushion to sit on sometimes, or putting these little feet under your sofa or chairs can make it easier to get up and down. You can get things that go around your toilet that can make the seat higher, which can make it easier to get on and off. And that's about reducing the effort of these tasks. Okay, so a bit of equipment can make the breathlessness you experience in everyday life a little easier and more manageable. Okay. Because it's unlikely that breathlessness is a thing you'll never have again. I think breathlessness is part of everyday life, but if it's bothersome, then we're trying to think of ways to manage it. So manage your life. A little bit about environment. So if you know certain things set your breathing off and make you more breathless, it makes sense to try and avoid them. So lovely sunny day today, people cutting the grass. If you know that sets your chest off, maybe to stay indoors if you know your neighbours are cutting the grass. Or if the park they're cutting the grass in the park, then maybe not take your walk around the park. Simple things that you probably already thought of. But avoiding exposure to allergens is a way of controlling your environment, or trying to control your environment and manage your breathlessness. Temperature control. So some people get more breathless when it's hotter. Some people get more breathless when it's colder, or more dry, or more humid. It really is horses for courses. So my mum, when we used to go to the zoo, would find that her breathing would get worse if we went in the reptile house, which is a warm, humid place. But lots of people, when we've had the cold weather, -2, the second they go outside, the cold hits their chest and they find that they're much more breathless. So some people will manage their exposure to that kind of environment by avoiding it, or some people will wear scarves or masks over their face, and that can help a bit. Or even this, getting your thermostat to the right temperature. It's worth experimenting and seeing if that helps. A lot of people find that when they're flaring up their chest condition, they'll fling open the windows or they'll go into the garden at 2 a.m. That can be a way of managing it. And you'll probably have read about fans. You might have seen or been given a little hand fan that you hold sort of close to your face. It's about exposure of this part of your face. So you can have little ones like this, which are quite quiet, but they can make a big difference to helping manage your breathlessness. Now, this is a face flannel. Some people find that a bit of lukewarm water or cold water, just moisten it and moisten this part of your face, and that can really help with the breathlessness. It works in a similar way to the cold air hitting your face from a fan, just some cool water. And some people don't like air being blasted at them, but sometimes a cool flannel can make a big difference. It certainly won't harm you. Okay. And then lastly, we sort of talk about all the different techniques you might want to use. So there's a bit more to these. So I try to split them into categories. So the first sort of category is the mechanics of breathing. So it's a bit tricky, but if you think about where your diaphragm is, it's below your lungs and above your belly, really. So when your diaphragm contracts and descends, it pushes your belly forwards, which you can see that sort of person with the black vest. So the left picture is someone who's breathed out, and the one is, if your shoulders are up like this, you'll tend to use all this part of your chest to do your breathing, and the muscles up here aren't as strong. These are what we call the accessory muscles, or the extra muscles of breathing, and they can be useful, but they're not as strong as your diaphragm. So for most people, trying to relax your shoulders and breathe using your tummy is a good thing to practice. And then hopefully you can sort of access some help to, if you can't work out how to do it, a physio like me or some online resources might be able to give you some ideas on how to practice. Not everyone does this instinctively. So in my physio class, when I was at university, about 1 in 3 of my class would tend to breathe up here, and I was one of them. But with lots of regular practice, you can actually get your breathing to be from your diaphragm a bit better. And that means you don't need to put as much effort in, which means you get less breathless. Okay. To manage exertional breathlessness, so getting short of breath when you're doing stuff, one of the things you can do is pursed lip breathing. So that's the picture on the top right. It's on the push or on the breath out, you purse your lips, and this has an effect on what's happening inside the tubes of your lungs, because you put a bit of resistance there by making the hole that you breathe out through smaller. airways are a bit wider, it's easier for the stuff to get out. And the stuff I'm talking about really is carbon dioxide. Carbon dioxide, remember, is the gas that makes the acid that makes your breathing faster. Remember, not so much oxygen, it was acid and carbon dioxide. So if you're able to get rid of carbon dioxide better, it tends to relieve breathlessness a bit better. Okay, so that's pursed lip breathing. And you might hear the phrase blow as you go. And that's what they mean during exertion. And that can really help manage breathlessness. Breathing through your nose, not everyone can do it, but it tends to warm the air, particularly on the way in. So if things set, like cold air set your breathing off, if it's warmer and more humid by the time it hits the sensitive bit of your chest here, then it's less likely to be irritating. If you breathe out through your nose, again, that will tend to slow things down, but a lot of people will find that difficult. So that's why you hear the sort of in through your nose, out through your mouth. But when you're really short of breath, you'll tend to want to breathe through your mouth anyway, because there's less resistance to flow, and that's okay. All right. So in terms of mechanics, those are sort of the techniques to use. I can talk a bit more about that at the end if people want. In terms of positions, it's really what works for you. Most people are at home when they're breathless will just sit down and recover their breathing, but forward lean standing is quite good actually. So if you've got a chair or a kitchen top to sort of lean on, that's quite useful. If you've got no sort of chair to hand, so that you're walking down your road and you don't want to lean on people's front garden walls because they'll look at you funny, you can use an umbrella or walking stick as something to lean on. Don't think, or whatever's to hand. If you've got a handbag, there's a picture bottom left, so you might be able to rest your hands on that, or in your belt loops or in your belt, so you can actually fix your arms. And it's about fixing your arms. By fixing your arms, whether it's a trolley or a chair or a wall, forwards like this, it enables these accessory muscles at the top to work in a different way. So it's a way of giving your breathing muscles a different way of working, which actually means they won't be as tired. There's a bit more reserve there to call on, which is useful, while the other ones, so maybe your diaphragm and the other muscles of breathing, have a bit of a rest. So it's an extra sort of boost that you can call on when you need it. Okay, so forward lean standing is actually one that most people will find helpful if they're very short of breath. I use that a lot on hospital wards with patients. There's a picture of someone lying on the sofa there, propped up nice and high on their side. For some people, side lying in that kind of position works best. In terms of frequency, I wouldn't say it's one that most of my patients have found to be massively helpful, but it's an alternative you can try, and it might be the one that works for you. Okay, so positions can make a difference in terms of recovery and breathlessness. So timing techniques, there are loads of these. Generally speaking, perfect breathing and nice relaxed breathing, you would have the breath out taking longer than the breath in. So new and out for 3. So all of these timing techniques will involve prolonging the breath out, and there is a mechanical reason for that. So if you breathe normally, the breath in is the active bit and the breath out is the passive bit when you're breathing normally. Okay, so breathe in, you use muscles, breathe out, it's elastic recoil. Yeah. Now the breath out would naturally be longer for that reason. And your body's geared up for that. And remember, when you breathe out, you're getting rid of carbon dioxide, that gas that makes you feel breathless. Okay. So if you are anxious or panicking, it's about a 1-to-1 ratio. Not only am I breathing more breaths per minute, which uses more energy, but I'm not giving the breath out a chance before I take my next breath in. So what that tends to do is it tends to trap air in your chest. This is particularly the case with conditions like emphysema. Okay, so if you trap air in your chest, it means that when you try and take the next breath in, your lungs are already partly full. So you're trying to fill already full lungs, which takes a lot of energy because you're fighting against the recoil of the chest. Your chest is wanting to recoil and let the air out, but you're fighting to get air in. And when you're fighting to get air in and your body's making that difficult for you, that compounds anxiety and worry and panic and those kind of feelings. So sometimes something as simple as prolonging the breath out can really calm things down, make your breathing more efficient, and that breathlessness improves. Okay. So I like to give people a visual cue to concentrate on, and a door is a nice one in that it's got about the right ratios for breathing in along the shorter edge and breathing out along the longer edge. And when you're breathless, the temptation is to accelerate your timing. So you go faster down the long end of the door, but try and keep the speed the same as you're breathing round the rectangle, whether it's a door or a computer screen or a mobile phone or a magazine, any rectangle really. And that sometimes can help settle your breathing back into a normal, more easy to cope with pattern. You might come across the 4-7-8 breathing method. This is one where you breathe in for the count of 4, you hold it for a count of 7 and breathe out for the count of 8, while exhaling, making a whooshing noise. But I don't think that's particularly useful for people with respiratory disease myself. But there's no harm in you trying it. There are lots of phone apps around breathing and timing and relaxation. You can try them out and see if they help you. But the general premise of all of these is it's about prolonging the breath out a little more. So making sure that the breath out takes longer than your breath in. And in terms of a visualization, I used to tell people on hospital wards to imagine you're smelling the flowers and blowing out candles. So and that simple sort of visualization will help get the timing right. Timing during activities, well, a lot of people when they have breathlessness at home, they talk about breathlessness when they are walking up stairs. And again, you can try and match your breathing to the stairs and try and experiment with different timings. There are examples on there on the slide, which I won't go through right now. But essentially, it's about either slowing down how quickly you go up the stairs, or it's about prolonging the breath out as you do it. Okay, so timing can make a difference. I don't really want to talk about anxiety management because I'm not a trained counsellor or psychologist. There are techniques to help people manage sort of anxiety, and a lot of these might be given to you by practice nurses or Macmillan nurses, or you might get a leaflet on these. The 5-4-3-2-1 is one that's gained ground over the last couple of years, especially, and it's got a lot in common with mindfulness, which I know Graham's talked about before. a few times, and I think we had someone come in and talk to the patient group a few years ago about it. That's about grounding you where you are, and sort of interacting with your environment in a different way. So acknowledge 5 things you see, acknowledge 4 things you can touch, acknowledge 3 things you can hear, acknowledge 2 things you can smell, and acknowledge 1 thing you can taste. And by going through those steps, it takes you away from the breathlessness, and it makes you acknowledge the environment you're in. And for lots of people, that can help settle the nerves or the worry. The technique on the right is one way of getting your body to relax, and it's basically a hold relax technique similar to the Alexander technique. What's probably helpful is if you get someone to read you the script as you do it, or do it together, and then get in the habit of practicing that regularly. So when you're feeling okay, because when you're not feeling okay, the last thing you will be able to do is, all right, where's that bit of paper on how to relax my body? It just won't work for you. So it's something you can practice if you don't have a way of relaxing your body already, other than sleep, of course. It's a way of getting your body to relax. And remember what I was saying about where you breathe from matters. If you're up here, your breathing tends to be less efficient. You have weaker muscles that tire faster if you're up here. So if you can get your body to just relax, your breathing often improves. And that's why I talk about progressive muscle relaxation in this talk. Okay. Other stuff. Okay, so you might have been told to imagine that you're on a lovely beach with the waves lapping, that kind of stuff, as a way to take you away from the scary room where you're breathless and get you thinking about something that makes you feel happy, relaxed, and safe. Now, a beach to you might be the bottom picture, but it might be Blackpool. And for me, Blackpool wasn't that relaxing or happier place. But that's another story for another day. No offense to Blackpool. It might be sort of go to your cave and be your spirit animal. I've heard that on, for example, the movie Fight Club with Brad Pitt. And again, that wouldn't be particularly helpful for a lot of people to imagine going to a cave and imagining I think it's a penguin in the movie. I don't think that's particularly great. But imagining a place where you do feel safe and happy, or you feel at peace, that might be helpful for you. But to do that, you have to shut your eyes and really concentrate and take away the external stimuli. And that's very difficult if you're acutely or very suddenly breathless, or if you're so breathless that you're really having to concentrate on your breathing. That's quite a skill, and it's not for everyone. When my wife was delivering our second child, the midwife had given her a technique which is on breathing out. Imagine that there's gold thread coming out of your mouth, and as it comes out, it sort of fills the room. So she was doing her pursed lip breathing, blow as you go. I thought, oh, that's brilliant. So I'll tell my patients about that. I haven't had a patient yet that's found that particular one to be the thing that cracked the nut of breathlessness, but I thought I'd mention it. But these are like examples of visualization techniques, and you might find your own one, and sometimes they're very helpful for people. Internal dialogue, this really is you talking yourself through the process of a breathlessness episode. A lot of people living with lung problems, for example, will experience things that set their breathing off, and it can have an obvious trigger, or it might not have an obvious trigger. But a lot of these episodes have the same kind of pattern. So you might find that, well, before I get really breathless, I know that my palms start sweating. or I can feel a bit of tingling around my mouth, or my back starts hurting a bit. And there might be, and you experience sort of various things along this pathway of going from I'm okay to really breathless. And it tends not to be on the flip of a coin. It tends to be in steps. Okay. And internal dialogue is a way of acknowledging the steps as they happen, to anticipate what the next step is, and to acknowledge that it's going to go away. Okay. And just internalizing that sort of experience and the steps along it can often help you feel more in control, and not worry so much about the breathlessness. Okay, so that's something that some people find helpful. Rehearsals, this is sort of planning, really, and it's planning to what will I do if I feel breathless when I'm. So for some people, it's like, say, going shopping to the supermarket. So what am I going to do if I get breathless at one end of the aisle? So in your head, you might rehearse, well, I remember that leaning on the trolley, I might lean a bit heavier and have a stop and a break. Okay, that might be one thing that you rehearse. Another thing might be, well, I'll make sure I've got my inhaler in my bag before I leave the house, and I can use that. You might say, well, if my breathing doesn't recover and I'm still breathless, I might go and sit down at the cafe and take my trolley with me, or I'll ask someone to look after my trolley while I go and sit down. So there are ways of rehearsing things in everyday life that you might anticipate. Well, if I get breathless, then there'll be a problem. It's having sort of things in your mind planned out on how you might manage that breathlessness. So rehearsals can make the impact of breathlessness a lot easier to take, because you'll have strategies to help cope. Distraction. So some people find soothing music helpful for calming the breathing down. So listening to whatever works for you, really. It might be techno music, it might be whale song, it might be sounds of the rainforest, it might be a bit of Simon and Garfunkel. It's a way of thinking about something else, and that can help change the experience of breathlessness and help you relax. Sometimes think distraction about something else. So trying to do a crossword, or someone says to you, oh, look at that over there, you know, there's a squirrel that I haven't seen that one round here, or look at that strange bird. And because your mind changes from breathlessness to, oh, that is interesting and different, distraction is quite useful. A lot of carers or spouses or children use this with their parents, or parents use it with their children. Distraction is quite a powerful thing, and can be very useful. We briefly mentioned mindfulness. Some people get a lot of benefit from that. And I would say planning, prioritization, and pacing is stuff you probably have always thought about. So planning links nicely with rehearsals, doesn't it? Prioritization, if you're having a good day, maybe don't try and do everything, but do the important things, and make sure you manage your activities so you don't get so breathless, and doing them at a rate that controls your breathlessness. So pacing the activity can make a big difference to how breathless you feel. So maybe clean up half the room rather than the full room, and then have a bit of a sit and a rest, or the hoovering or whatever it is, or peg out some of the washing, have a rest, and peg out the rest of the washing. Last thing on this slide is acupressure. So I'm not an acupuncture trained physiotherapist, so those are people who stick needles in you, but acupressure is it's gained a lot of ground in the last few years, I suppose. Acupressure at this particular point it's not just for breathlessness, it's for pain as well. But if you have the web of your hand and you put some pressure here, so it's uncomfortable, and keep the pressure there for 20 seconds or so, that for some people can help relieve breathlessness. Again, in my personal experience, it's not something I've witnessed to be helpful, but it is out there on the net as an experience. And a lot of the hospices around the UK will sort of mention this as a technique. Another technique from, well, back in my past, another pressure point was the philtrum. So between the sort of this bit of your nose, the septum of your nose, and the top lip, apparently pressing there can be helpful for breathlessness as well in terms of acupressure points. Again, when trying this with patients, I haven't had the most success. Okay. Just to finish off, before we get into a chat, make sure if you're worried about breathlessness, you've mentioned it to your doctor and your family, because there's a load of things that maybe we can investigate and treat, or we can help you manage it better. Okay, so it's not all on you to just get over it or just cope better. Other people can help you. Okay, there are things you can do yourself to help manage your breathlessness, which I've touched on in this talk. Try and understand what makes you breathless in everyday life, so you understand what your normal reactions are to things, and try some techniques to manage your breathlessness. And if they're unsuccessful, maybe try something different. If they're unsuccessful, maybe think why that was unsuccessful. If you're not managing, talk to people. It's really important, really important. And it's not just health professionals that can help you. So will and friends and groups like our patient group, there's a wealth of experience of top tips that people will come up with just by living with this. And it's so valuable to learn from people. And I would say finally that just because you're breathing a bit faster doesn't necessarily mean something's wrong. I get breathless every day. If you're talking that breathlessness is faster or deeper breathing. And certainly if it's linked to exercise, I'd encourage you to exercise. It's so important not to fear deeper breathing that's related to exercise, because that's your body's normal reaction to exertion. And the fitter you are, the healthier you are, generally speaking. Okay, that was a bit of a whistle stop tour. I will stop sharing this, and then I can see your gorgeous faces. And there we go. So, now I can see the chat bit. Let's have a look. Okay, I've got anxiety about breathing is perfectly usable. Okay.
Phil?
Yeah.
We're going to direct the questions from the chat to you, if that's okay.
Oh, sure, yeah. I'll do my best.
If anyone's got questions, can you drop them into the chat, just because it makes it a little bit easier for us to make sure everybody gets the questions answered, rather than people raising hands, because some people aren't on video. So if you're raising your hands to a non-working video, we're not going to see you. So if everyone can just drop them in the comments in the chat, and we'll go through them from the top with Phil.
Okay, so do you want to start with the top and then work down? Okay, let's have a go.
One of the first questions we've got, Phil, is from Sheila, and it's, why does breathing in through your nose and out through your mouth make you dizzy?
For most people, it shouldn't make you dizzy. So the thing that tends to make people feel dizzy is if they overbreathe or breathe a bit faster. So if you've got some blockage, maybe, I don't know if Sheila's nose is blocked, but sometimes if you've got a bit of blockage and there's more mechanical work required, you'll automatically try and go a bit faster. So generally speaking, in through your nose and out through your mouth shouldn't make you feel dizzy. It's not something that I've come across with any patients really, but that doesn't mean to say it's not Sheila's experience. But obviously, if something's making you feel worse by doing it, don't do it that way. There are general principles around breathlessness management, but they might not apply to you, which is why it's important to have a range of things to try. Okay.
How's that, Sheila? Have you got anything you want to add to that, Sheila?
Yeah, I suffer with vertigo quite badly.
Oh, okay.
And yeah, hello. And also, I think, because my sinuses are playing up, I think I've got polyps on this on one side. So I think that could be it.
Yeah, there are a number of patients who've got polyps, and significant polyps, and they've been told to breathe through their nose, and they go, I just can't do it, and you just can't because of the blockage. So yeah, don't worry if you can't, but that might be a contributing factor, Sheila. Okay.
Well, I was sitting here breathing in, which was fine, and then when I was breathing out, I was going completely wobbly.
Oh, well, don't do that.
Thank you.
No problem.
Okay, so the next question we've got, Phil, is from Gwyneth, and she asks, does holding breath in help increase lung capacity used over time? For example, in 4, hold 2, out 4, hold out for 2.
So let me just check I've got it right. So she's asking, if you breathe in and hold your breath, does that improve your lung capacity?
Over time, yes.
Over time. Okay. So breath holding is a technique physios use when people have lung collapse or atelectasis. So sometimes bits of your tubes collapse down, and to get them expanding again, we get people to take deep breaths and hold it. And what happens when you do that is air kind of sneaks around the back of the obstruction and helps inflate the bit that's collapsed down. And this is kind of why people yawn or sigh. So every now and again, everyone will occasionally take a big breath or a sigh or a yawn. And that's because normally you don't use all of your lung tissue, your lung airways. And if you don't use them, they kind of collapse. They have a tendency to collapse. So that deeper breath is a protective mechanism. And in hospitals, after surgery or those kind of things, you're prone to collapsing bits of lung down, and you might be a bit more prone to collapsing bits of lung down if you've got a lot of sputum that doesn't move or mucus that doesn't move. So if you have a collapsed bit and you do some deeper breathing, it can inflate bits of lung and increase lung capacity. That said, most people that won't apply to. So if I was to practice holding my breath, my lung function won't improve at all. It won't make any difference, because those occasional big breaths that I take will keep on top of that potential to collapse. Okay, so it's unlikely to improve your lung capacity.
Okay.
Anything else, Gwyneth?
I do it as part of a yoga thing.
Okay.
And I was somebody mentioned to me recently, a nurse, that by doing, that ratio, 2, 4, 3, 6, whatever, that I would increase my lung capacity.
Okay, I would say that's not true. So that's my take on it. I can't see how it would. There is a thing about breath holding with people who hyperventilate or overbreathe. So some people have just got in the habit of breathing a bit faster than they should. And one of the possible reasons that they do that is their brain, that detection of carbon dioxide, they detect a normal level of carbon dioxide as high. So they're stimulated to breathe more and breathe faster, so they overbreathe or hyperventilate. So one of the things you can do with patients who hyperventilate, and I used to do, is I'd work on the timing as well, but one of the things I'd check is how long they can hold their breath. Because what happens when you hold your breath is your blood carbon dioxide level will creep up because you're not blowing it away. Okay, so by say you're really sensitive to carbon dioxide, and that's the thing that drives your breathlessness. You won't be able to hold your breath for very long. But if you practice breath holding, you might reset that sensitivity in your brain, and you might find it easier to hold your breath a bit longer, and then you feel less breathless. But when I was treating people for breathing pattern disorders or hyperventilation, I wouldn't use that in isolation, breath holding. I'd be thinking about the mechanics. Can I get their shoulders down and then use your diaphragm better? And can I get the out breath longer than the in breath? That was always my focus. Okay, so that's a little bit more about breath holding. Okay.
Okay, thank you.
Most welcome.
Had a couple of people ask, can you re-show the pressure points, the active pressure points on the hand?
Can I what, sorry? Oh yeah, sorry, because had the slides up, I couldn't. So yeah, so you've got that bit of your hand, you've got the fleshy bit here, yeah? So there are two different approaches. You can just do the top, so there, yeah, so squidge in there, but with your hand down and relaxed. But I'm up to the camera to show you. So in there, or you can pinch. There we go. Very weird. So you can pinch that fleshy bit. But the reason I put the name of the point on the slides is you can Google it to your heart's content, because after this we can put the slides up on the group, can't we, Graham? If that's all right.
Okay. We've got a question from Caroline. If you want to mute yourself, Caroline.
Hello. I just wanted to ask about breath holding, because I think I read somewhere that if you do that during the chest clearing, some of the breath holding will help move the mucus because the air gets behind it. So is that a useful technique?
That's right. So every time that I teach airway clearance techniques, I'd always start with deep breaths. Now, there's a bit of debate as whether you need to hold the breath in for 2 seconds, 3 seconds, 5 seconds. I don't think it makes a big difference. I think the thing that makes the big difference, I think, is the depth of the breath. So it's as much air in as you can.
Right.
But you can argue that adding a hold to the depth of the breath will help as well. It certainly won't do any harm.
No.
There's another sort of way of getting extra air in round the back, which is you take your big breath and then you sniff on the top. And if you try that now, you probably find it quite uncomfortable. So you fill your lungs as much as you can, sniff, and then you'll have to breathe out.
Yeah, that is a bit tricky.
But if you're looking at tricks of getting as much air in and maybe really trying to force it round the back, but for a lot of people, they don't have it stuck, trapped, and blocking a tube completely.
No.
It's probably not as important, but it certainly won't do any harm.
Okay, thank you for that.
Okay.
Brilliant. And then we've got
I'm not sure how to clear that. No. The handheld, I don't know.
Famous. Excellent.
We've got a kind of question from Mark, and he said he really finds his mood makes a difference. So when he feels more positive, he doesn't feel as though his breathlessness is bad. He says it's perhaps endorphins.
So Mark was saying that when his mood is better, his breathing's better. Yeah, and that's definitely the case for a lot of people, and it probably boils down to a number of things, but the mechanics certainly change. If you're looking at people lined up for a job interview, you can spot the anxious ones, can't you? Because they're not sat all relaxed and like that. And when you're up like that, your breathing tends to be less efficient. I will give a sort of caveat to that, in that if you have emphysema, and sort of quite progressed emphysema, you will tend to trap air in your chest, and you will have to breathe up here. with severe emphysema, you have to breathe up here. And what happens is there's an adaptation as your lungs change. So as your lungs change, your circulation to your lungs changes with emphysema, and it can distribute the blood to the top, to where the air is going in and out. So if you try and breathe from your tummy and all the blood is up here, then actually your blood's not going where the oxygen is. So for some people, breathing from your tummy will make things worse. But I digress. Mood can make a difference. What was his question, or did he not have a question?
It was because he said perhaps it's endorphins.
Endorphins. Oh yeah, absolutely. So endorphins can alter the sensation of breathlessness. So the bits of your brain that control mood feed into your breathing center in your brainstem, and we certainly know that can change the way your breathing is stimulated in that part of your brainstem, which is how morphine or opiates can help with that breathlessness. I was saying that there's medical treatment for that. So endorphins are the natural morphine of the body, really, which is why exercise is so great, because you get endorphins.
Thanks, Phil. We've got a question from Saraya on Facebook, and she's said she would love to know what the influence of the nose is on breathing. She says she's noticed that getting older, the nostrils are smaller, and allergy has a bigger influence. She says all medical things concentrate on the lungs, while the nose can give more relief sometimes. And she says it helps her to place her thumb in the indent just behind the tip of the nose while keeping a finger on top, not pushing the nose down. She says just gently keeping it at the same place. She says it seems to open the nasal cavities, and she says it works for her.
Yeah, well, anything that helps, I'm all for. So she's saying if she pinches, is it here? Is that what you described about here?
I think so.
Yeah, it's hard, isn't it? But it's not something I've seen. But for there are strips you can get. Robbie Fowler from Liverpool back in the day, he used to wear strips across here when he was playing for Liverpool Football Club, and allegedly it helped him with his breathing during elite sport. So I certainly wouldn't discount it, but I'd say evidence-based, I haven't seen a lot that would support it. But if you've got something that works for you like every time, then that's the most powerful evidence there is, isn't there? Okay.
Thank you. We've got another question from Mark, and he asks, can vocal cord dysfunction also impact on breathlessness?
Massively. Yes, so vocal cord dysfunction, again, we've got lots of jargon terms around this. So there's inducible laryngeal obstruction, or ILO, vocal cord dysfunction, a few other things sort of bouncing around. And what tends to happen with vocal cords is if they misbehave and close off, it feels like it's in your throat rather than in your chest. It's in your throat. It's something that they can check for. There's an investigation you can have for that. So they basically put a camera up your nose and look at your vocal cords, and if they're not already irritated and misbehaving, they'll spray a can of Lynx or something similar at you and wait for them to misbehave. And if it is the vocal cords misbehaving or dysfunctioning, you can get specialist speech, voice and swallowing therapists or speech therapists to teach you ways to manage that. Okay, so there are techniques specific to vocal cords that can be shown to help you manage that, which I won't go into because I'm overstepping my professional boundaries there. But from what I understand, they're quite simple to do, and they can be very effective. It tends to be people who, if you for vocal cord dysfunction, tends to be people whose asthma doesn't seem to be well controlled. So if your asthma isn't being controlled very well, then by your GP, make sure they refer you to a specialist centre where a respiratory consultant can do the appropriate tests because it's really come into the forefront of asthma care in the last 5 years, I suppose. Increased awareness of vocal cords. Okay, but it's quite rare as a condition.
Brilliant. Okay. We've got another kind of question from Facebook again, and this question says, breathlessness at night and using ventilator and inhaler during the night. So sometimes you can just go back to sleep, but other nights need a couple of puffs and has no idea.
So the person on Facebook's saying that sometimes Ventolin helps them at night with their breathlessness, and sometimes it doesn't. And I'm guessing they want to know why that is.
That's me, Phil. That's me, Phil. Why do I wake up breathless in the night? Tell me why. Why do I wake up breathless in the night? What?
Okay, so with breathlessness at nighttime, there's lots of reasons why it's nighttime. So I'll be here a while. I'll be here a while. So sometimes it's medication wearing off. Sometimes it's mucus and where it's shifted because of your body position. Yeah. Sometimes it's to do with hydration status. So as you get more dehydrated, your nerve endings are more exposed and you're more likely to get set off. Nighttime, your heating isn't on as much. So particularly around these minus as we've had lately, colder bedrooms might set your breathing off differently. That's just a quick view. It's very hard to tell you exactly why, and I'm not sure I'll ever know the answer, but I suppose how you deal with it. So in terms of medical management, for example, with inhalers, some inhalers last 4 hours, 8 hours, 12 hours, 24 hours, and so sometimes it's optimizing your medication regime or indeed the medications that you're on that can make a little difference. So
take them later then. Take Seretide or something.
Perhaps, yeah.
Rather than exactly 12 hours.
If you make a change and then evaluate how that change impacts you, then you know if you try and do everything at once, you'll never know. So,
no, that's brilliant. That's a good start. Thank you, Phil.
Well, absolute pleasure. Nice to see you. Okay.
Phil, and then we've got another question from Facebook, and it's from a lady called Jen, and she said she's really suffering with breathlessness. Last October, she was cycling 35 miles, hiking 15, and climbing between 2,000 and 5,000 feet. She says she can now only walk on the flat a short distance and has pain in her right lung where her fungus ball is. Says, however, a consultant has said it's her asthma causing her the problems and not the fungus. She's been started on lots of different medication, but really wants to get back into more physical activity as she exercised previously to all these problems.
Okay. So that's what's up with her. What was her question? Sorry. Did she have a question?
Yeah, she's kind of. I think she's kind of looking for an explanation why the consultant's saying it's her asthma and not the fungus that's causing it. But she's presumably. All I've got is this information, but I'm assuming this lady. So it's really difficult to sort of talk about people's individual healthcare problems and their history and all that kind of stuff. So I suppose a more general question, which I can have a stab at, is how much of breathlessness can we lay at Aspergillus, that annoying fungus that we sort of struggle to pronounce and get the message out that it's a thing that's everywhere and can cause a lot of misery for people. So if we're talking about fungal balls, a fungal ball tends not to be a mechanical reason that you'd feel more breathless. So if you cut out one of my lungs, you probably wouldn't notice that Phil was suddenly really breathless very easily. So a fungal ball in a cavity on its own as a cause of breathlessness, mechanically, not really. Fungal balls can secrete stuff that makes you feel lousy and tired and knackered and grotty. And we know about that. So in terms of energy levels and breathlessness in that sense, yes, perhaps. But we tend to know that fungus was
very active and doing lots of stuff to tie in with those kind of symptoms. Now, if we're talking about a different kind of Aspergillus disease, so allergic bronchopulmonary aspergillosis or ABPA, or asthma with fungal sensitization, or even severe asthma with fungal sensitization, you've got to think of the aspergillus as the thing that makes the asthma worse, and it's the asthma that gives you the misery. And in this person's case, it might be that that's the kind of disease they've got. And I suppose antifungals for those people can sometimes help how irritable their asthma is, but it's the irritability that's the problem, not the fungus. Do you see what I mean? So I've nicely skated round the problem and not really given an answer, but the bottom line is I don't know for that person.
So generally, in that, this person has lost an awful lot of physical condition and physical ability suddenly. Is it reasonable to suggest she will regain that in the nearish future?
It's so hard without knowing this person's investigations, etc.
Not this person specifically, but generally, just because you've lost a lot, it doesn't mean you won't get it back at some point. No.
So it doesn't necessarily mean you won't get it back, but in terms of recovery or rehabilitation, it's the thing that frustrates people is quite often not just how quickly it goes, but how slowly it comes back. So you see this all the time in hospitals when people have a protracted hospital stay or a long illness, for example, coronavirus, that's topical. So people recovering from these things, and it's absolute frustration. You could be fit as a flea, and then something hits you, knocks you for 6, and then it takes time to build that back again. And that journey is going to be unique to that person. And it can be really frustrating because you can go, well, my mate Dave, he had the same thing wrong with him and he bounced back in 3 weeks. And here I am 3 months down the line and I still can't do. And in terms of recovering from things, I think it's very important that you understand the progress or the changes that are happening, or however small they may be, and see them as the positives they are. And if you're not improving, then obviously talk it through with your healthcare team, whether your GP or your consultant or whoever, and try and see the gains. Know where bottom was, acknowledge where bottom was, acknowledge where you were, and then think of how am I going to climb back to where I was. And have that discussion with your healthcare provider about, I want to be there. How are you going to help me get there? What's the timing of that's realistic? Okay, and if plan A doesn't work, what's plan B, plan C? And have those kind of conversations, rather than suffering, frustrated and annoyed that I used to be this, because that doesn't help you. Okay.
Thanks, Phil.
No worries.
Gwyneth, she asks, why does tiredness make, I'm assuming you mean your lungs tight, Gwyneth? She says, or is it just that she's not pacing herself?
Why does tiredness?
I tell you what, Gwyneth, do you want to jump in?
Sorry, I find sometimes I seem okay. I've not been well for the last 6 months on and off. I find that sometimes I feel like I'm having a reasonable day, doing stuff, might have gone for a little walk. I feel okay, and then suddenly I get tired, and within a few minutes of realizing I'm really tired, I get really short of breath, really congested. Now, sometimes I take Ventolin at that point. Sometimes I forget, and I go and sit on the sofa and realize, oh heck, I haven't taken Ventolin. Too tight to get up and get it. But within, I don't know, I watch something on TV, so distraction. I think, oh, I'm not tight anymore. Is it just I got tight because I'm tired? Or is it, like you were saying, like an ABPA sort of reaction? I don't know. How can I stop it happening? How can I stop it happening?
I'm not tired, and the same exercise sometimes makes you tired and sometimes doesn't make you tired.
Yeah, probably. But I've been very up and down. since October.
I mean, you could think about environmental reasons, which obviously I can't tell you what they are. Timing of medication, again, maybe. You know, I took it at 9 o'clock that day. I took it at 10:30 that day, maybe. Then, yeah, I don't know.
Is it chemical? Is it when you get tired? You were talking earlier about the floppy airways. Is it if I'm tired, they will have, I don't know, collapsed in some way?
No. So fatigue doesn't, or tiredness doesn't affect your respiratory airway muscle. So the muscle that goes round the tubes of your airway. So there's certain sort of conditions that make your airways obstruct more or floppy. So things like COPD and emphysema, for example, bronchiectasis as well. You can tend to have a bit more floppiness to your airways. Asthma tends to have you have the thicker muscle and the more mucus. But again, sometimes with asthma, you can get a bit of extra floppiness. So that, particularly in the big airways, you can get some changes with that. So it's hard to say, but what's definitely true, Gwyneth, is people, including myself, have good days and not so good days. I think that's just par for the course. I think when it's knowing how to cope with the downs as well as the ups, and having those strategies in place, and maybe have your Ventolin a bit closer so you don't have to get up to okay.
I try not to take it, which I've had to take it a lot lately. And that's the thing. I mean, you were talking earlier about breathlessness and leaning on things and doing different physical techniques. I mean, should I do that before I take the Ventolin, or should I take the Ventolin and do that as well? What's the strategy?
Okay, so I've got to be careful not to take the place of your healthcare team. Okay, so I've got to be very careful with that, and I've got to say that you should use your inhalers as you've been told to take them. Yes. So these days with asthma management, for example, the drugs are better. They last longer, and that blue inhaler is there as a backup. Okay, so that blue inhaler, that Ventolin, most people shouldn't have to use that regularly. That's not everyone. Some people do need to use it regularly, but a lot of the treatments now, the Ventolin's the backup, and we're hoping you don't need it. Okay, so if the drug's on board and doing what it should do, then in theory you shouldn't need the Ventolin if you've got asthma. So that's what they would try and do. The great thing about Ventolin is if it is bronchospasm that's making you short of breath, Ventolin acts straight away. It's really quick acting, and you get lots of action very quickly, and it relaxes the muscle and it helps you breathe better quickly. If it's the muscle around the airways getting narrower, like that, it will relax it very quickly. So it's great for doctors, because there's asthma, take that. Oh, I feel better. What a brilliant inhaler. But if you're thinking about, well, if I'm at the top of the stairs and I'm short of breath, am I short of breath because my asthma's bad and I need my blue inhaler? Or is it because I've just climbed the stairs and I just need a bit of time? And there are a lot of people who will use the blue inhaler at the top of the stairs because they think they need it to relieve their breathlessness. I'm not saying that's the case with you.
No,
but
I'm the opposite.
A lot of people misuse Ventolin to manage breathlessness, and then they end up with things like their heart racing and they're all jumpy like this, and they're missing a trick, really. So there are a lot of people that I used to spend time with when I actually was a proper physio, doing proper physio work on hospital wards, and I'd take people up and down the stairs and we'd have the blue inhaler with them, and I'd say, well, let's just stand there for a minute, or let's just have a sit down, and if you're still breathless in a minute, well, yeah, there's your inhaler, and you're perfectly safe. I'm with you. And I can't think of a single person that actually needed. No, maybe one well, I've been working a while now. I can think of one person in my career where that stair example, they did need their Ventolin. Everyone else was managed with rest or forward lean standing, leaning against the wall, or having a sit and putting their elbows on their knees and leaning forwards, much as I am now, but you can't tell because the camera's funny.
Okay, that, yeah, and that's how I normally sort of work it. I mean, I can feel like it's getting tight, and then I'll try and do deeper breathing or whatever, and I don't take Ventolin. But over the last 6 months, on and off, it's just get tighter and tighter and tighter, and I have needed the Ventolin. But yeah, maybe I need a better, long-acting one. But yeah, that's fine. Thank you very much.
Yeah, if that's the case, then obviously that's an easy change for your GP to make, and for you to evaluate. The person living with this is you. So it's I mean, they can do blood tests and breathing tests and stuff, but ultimately the evaluation of the treatment success is you.
Okay, thank you. Yeah.
Okay.
Phil, are you okay for time? We've just got a couple more questions, if that's okay.
I'm having a lovely time. I'm in my front room. My family are quiet in the other room. And I'm not being bothered. So yeah, as long as we need. Not a problem.
Jill, do you want to just unmute yourself and you can ask Phil your question?
Hi, Phil.
Oh, hi, Jill.
Yeah, I've just had lung function tests because my breathing has got a lot worse, and they've said that I know my CT scan is pretty duff because I've got microbacterium abscesses, but they told me I have a problem breathing out. Now, is there anything I can do to help myself? They don't know at the moment whether it's due to a blockage or the damage or narrowing. They've got to do more investigations. But what can I do?
What can you do to help you breathe out? Unfortunately,
nothing.
I don't think there is. If it's a mechanical thing, and lung function departments are brilliant at looking for mechanical reasons for difficulty air going in or air going out, and if they've picked up like going out that there's something getting in the way, there's not much you can do. You can't sort of shove a curtain rod down and then make the tube a bit wider for you to breathe through. I don't think there's anything you can do, Jill.
Okay.
I'm so sorry. It just needs further investigation and then see if there's a treatable cause. If it is stenosis, they've got to understand what they do about that. Okay.
Okay. Thank you.
Thanks, Phil. And then
no worries.
We've got a question from Mel, and Mel, if you want to unmute yourself, if there's anything more you want to add. But Mel asks, why is breathing less easy in the morning? And if you want to talk more about that, Mel, you can jump in.
Okay, so this lady's breathing is worse in the morning and she wants to know why it's worse in the morning. Okay.
Mel, you're still on mute. If you're trying to speak, you're on mute.
There you go. I've unmuted myself now. Yeah, I noticed that morning time is my worst time. I do struggle quite often in the mornings. And as the day wears on, it improves, usually from about noon onwards. It starts to, lungs more relaxed, breathing's more easy, it's don't drive till that time and things like that. So I don't really understand. I know sometimes I cough and clear, and I can understand that's why, but some days it's just tight and there's no obvious cause to it unless it's got into the habit of being twitchy in the mornings or something.
Yeah, it's really hard to sort of tease out the exact reason why for you it's like that. I mean, I can ask about sort of the environment. So is it because it's a bit cooler in the mornings, and does that tend to make your chest worse? Is it around medications? Is it around what you've had to eat the night or drink the night before? Does that make a difference? So it's really difficult to say. I mean, certainly the day warms up as the day goes towards noon, but that's I'm clutching at straws, Mel. I don't know the actual.
I don't know. I mean,
I don't know for sure for you why that's the case. But
yeah,
there are, and it's interesting you talk about bringing stuff up, and you cough and clear, and that can be a reason. And that's true for a lot of people with sputum sort of problems. They have more breathlessness in the morning and cough a bit more in the morning. And if they cough clears some stuff, then their breathing feels easier. But that might not be the case for you. And it probably isn't that simple for you. But for some people, that's definitely a contributing factor.
Yeah, I mean, for me, it's much worse, obviously, if there's an infection or I've got a build-up and I haven't managed to clear it. And it just takes some cough, 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 so I do clear it. But I have noticed I got a little saline nebulizer, and I sometimes found I was using that. I mean, I don't use it every day by a very long way. But I used to find that seemed to ease, and I'm just now listening to you, I'm just thinking, I wonder if it means the central heating's made the air so dry in the house that might be irritating my lining in my chest, you know.
Well, it's really difficult to say. I mean, what your triggers are going to be your triggers. I think this, like all medical treatment, really is you change something and see what effect it has on you. So if you change, for example, your heating, or change your how you open how long you open your windows for, or those kind of things, and try and stop and evaluate it. But you won't know unless you've done it for a good number of weeks, probably. But yeah, I don't know.
I understand that. Thanks very much. Thank you. It's interesting to know that you can kind of approach it from that sort of investigating point of view and think, what can I do? And that helps from the point of view of thinking, well, there might be something I could do to make this better, you know.
Well,
so yeah.
Well, it also helps the conversation you have with GPs or physios or consultants or fellows or registrars or practice nurses. You can say, well, I know that this can sometimes influence it, so I've done this and it's not that. I've done this and it's not that. And it makes it a lot easier for people like me, sort of trying to help. Well, let's not like give you that to try. Let's give you this. So yeah.
I understand. Yeah. Thank you. Very good.
You're welcome.
So we've got another question from Teresa, and if there's anything more you want to add when I've read out your question, just feel free to unmute yourself. So Teresa's said that when she attends a consultation, they ask how breathless she is on walking. She asks, how are they defining breathlessness? Is it the point she starts to breathe harder, or is it the point when she needs to stop walking? And if there's anything you want to add, Teresa, just feel free to unmute and drop it. No, that's it.
Okay, so assessing breathlessness. There are a number of different what we call outcome measures, so ways of measuring it. So one way is the one we use in the Aspergillosis service, which is the MRC score, where you have like a list of tasks and you get a number next to each task, and as things get harder, you get a higher number. Okay, I'm not going to flash the thing up on this share screen thing because I'll make it crash, and we're doing so well. Okay, so they might use that as a thing to help sort of measure your breathlessness. Another one that they use in things like pulmonary rehabilitation, which is kind of a fitness sort of class or program that you can do. If you've got a lung problem, you can get referred to pulmonary rehab, and it's quite good. It's very successful, but the outcome measure they tend to use is something called the Borg breathlessness scale, and which is a brilliant scale because it's a 0 to 10, and you rate your breathlessness from 0, where you're not breathless in any way at all, to 10, which is the worst breathlessness you can ever imagine experiencing. Okay. And then they ask you, what number do you think you are when you walk to the shops or climb the stairs or right now while you're sat in the chair with me? sorry, next to me, not with me. That would be weird. So that's probably the easiest way of describing breathlessness, that 0 to 10, where 0 is nothing and 10 is just the worst breathlessness that you can possibly imagine. And they should help you answer their question. So how breathless? So, I mean, you can use terms like mild, moderate, severe, but it doesn't, it's a very difficult thing to measure. And there are lots of questionnaires that you can use to explore people's breathlessness, but they're pages long and they're not very user friendly, so which is why we don't tend to use them other than in research. So yeah, 0 to 10 is probably where I would go with if I was trying to answer that particular doctor's question.
That is a question they ask every time. I've got a consultant appointment tomorrow, and it's something that I dread when I go to an appointment, because I don't know what to say to them, because I don't know at what point they're asking me. And like you saying today, breathing hard is not necessarily breathlessness.
Well, yeah, well, it kind of, it's what it means to you, isn't it, really? So yeah, it's a difficult question to answer, but when you see that person tomorrow, tell them what you think. Say that when you ask me this question, this goes through my mind. So can you ask it in a different way, perhaps, that makes it easier for me to answer?
So
yeah?
my consultation is with Withenshaw, so I might just send them to you.
Are you actually coming tomorrow?
No.
Oh, okay. No worries. No, I'm not gonna hunt you down in your telephone consultation, but I'm around if they've got any questions.
Brilliant. We've got another question from Noel. I think I'm saying that right. And they ask, why might breathlessness?
One sec. Oh no, sorry, I didn't mean to. Oh yeah,
children off.
I didn't mean to. There we go. Sorry. There we go. So I'd locked the door and I've got the car key. Sorry, I'm back. Real life. There we go. Ask away. What's the question?
Noel asks, why might breathlessness be worse when speaking at the end of a long sentence, for example, and not so noticeable with exercise?
It's to do with the rate that you're breathing at. So when you exercise, you tend to breathe at a faster rate. And a lot of people, when they're doing a sentence, will do the full sentence in one breath and then do it like that. And so sometimes, again, speech therapists sometimes do this with patients. It's not very common, but in terms of pacing of speech, it's something you can practice. So I'm trying to think the best way to practice pacing your speech. I suppose it's practicing reading aloud. So if you've got children or grandchildren of the suitable age to read to them, maybe practice the same kind of stories, but trying to punctuate the sentences with more breath. So rather than doing it in one breath for 2 sentences, maybe one breath for half a sentence, and that might help manage breathlessness on speaking. But that's the only thing I can really think of. Okay.
Thanks, Phil. Another question from Mark, and he asks, how important is FEV1? But sometimes his FEV1 is quite high, yet he feels more poorly than on the previous test, and he's got severe asthma.
Okay, so FEV1 stands for the forced expiratory volume in 1 second. So in lung function, you're told to fill your lungs as much as you can and try to empty them as fast as you can. And the first bit of emptying your lungs tends to be around getting it out of the big airways. So the things like the trachea or the bronchi and the bigger bronchioles. And you'd want most of the air to go quite quick. And as you're getting more empty, it's harder to empty your lungs. Okay, so the rate at which you empty slows down. So FEV1 is that first second, and it's looking really about airway obstruction in the big airways. So if we're talking about here is asthma. Asthma tends to be more of those bigger airways because they've got the most smooth muscle, but it's not the whole picture. So you can have a flare up or an infection that's not affecting those big airways so much, but further down in your lungs, and that's where the problem is. And it might not necessarily be picked up by that FEV1 test. I mean, you'd suspect it probably should be, but it wouldn't necessarily be. So that's why that contradiction might be there. In terms of the importance as a test, it's useful for monitoring. So whether things are getting better or worse, it can guide us in terms of severity and what treatments you can get. But a lot of the time, it's not just the FEV1; it's all the rest of it. So the FVC and all the other measures that they make you do in lung function, and that's only one investigation. We try and look at the whole picture. Okay.
Brilliant. Thank you very much, Phil. So, Belinda, if you want to unmute yourself, I know you've not got questions per se, but I know you've got a few points that you'd like to discuss. If you want to unmute, and then it'd be a bit easier if you can make those points yourself. There we go.
Okay, so I made the point that let me just go back to make the points. I said anxiety about not being able to breathe is perfectly reasonable. I don't want to stop feeling anxious about it, because it's a natural thing. If you can't breathe, asthma can be, it can kill you. If you don't feel anxious about that, then it could be dangerous. And that's another reason why I would argue against trying distraction things, because you might not realize just how much worse you're getting. So that were the small points I'm making there that I would argue about. Coughing up phlegm can actually bring on asthma, but of course it's important. I don't like the term perceived breathlessness. It is breathlessness. Where, we know, a lot of us are very experienced at this, and we know that we must lean on things. We have to lean on things. So it is breathlessness. It could kill us. And so for another helpful thing would be, take a phone with you whenever you are out, because you may need to call 999. I don't like the idea that everything needs to be managed as if somehow you're stuck with this. There are a lot of drugs to help us, and I really agreed earlier that salbutamol can be relied on a little bit too much, and indeed my own GP has said that to me. If you're using it too much, you might need some help, rather than management techniques, distraction techniques. I could die. My technique is to go to A&E. Or my doctor consultant, if they stop postponing my appointments that I really need, to try and get another drug maybe. The other point I was making was about lung function tests. Lung function tests can be terrible, and the people that are having to do them are the people that can't breathe very well. So they can be really stressful and make us worse. And we're talked to like children a lot of the time, which can be awful if you've had a terrible childhood and you didn't enjoy that very much. Sometimes a consultant has once said to me, I don't need you to have all these tests. I can see exactly what's going on and you need help. I'm sorry I haven't asked an actual formal question, but I do think these points of view are just as valid and important to be heard. And maybe some of you might agree with me. Thank you.
Thank you for sort of saying those points, Belinda, because I hope I wasn't belittling what it is like to live with severe asthma and the significance of breathlessness. Absolutely. One of the reasons early on in my talk I was talking about safety nets and sudden breathlessness that's that gets you. That's a very serious thing, and I absolutely agree with you. Absolutely agree with you.
Okay, and if anyone else has got any questions, I think we'll let Phil wrap it up there, unless anyone else has got anything they want to add.
I've just got one question I'd like to ask.
Yep.
I haven't had asthma very long. Well, that's not right. I've had it apparently since 86, but it's only been bad the last 3 years since I've been diagnosed with sensitivity to Aspergillus. Now, I've always been very fit, and it's happening now, actually. I can be walking around and I'll phone my sister, who's a severe asthmatic, and she'll say to me, "How are you feeling?" I say, "I feel fine." She says, "You sound absolutely awful." And I said, "Well, I'm a bit breathless." So she said, "Well, have you taken any of your inhalers?" So I said, "Well, I take my frost air 4 times a day." So I said, "I've done that." She said, "Well, you need your Ventolin more." She said, "You sound awful." I know I'm breathless, but I don't know whether I need the inhaler. I don't know. It sounds odd. I don't really know how to manage my condition, is what I'm saying. And I don't know when it's bad. I know when it's really bad, but when it's starting to get bad, do you take the Ventolin to stop it getting to the point when it's really bad? It sounds really odd.
It's kind of a discussion you need to have with your the person who's managing your asthma. I suppose the interesting thing to me is, if you hadn't had the phone call to your sister, did you say? Yeah.
Yes.
You wouldn't have known there was a problem. Yeah. And
I would notice,
because she's the one who's got that seed of doubt in your head of, actually, am I all right? Am I all right? I don't know. Am I? Because when you was talking to her on the phone, presumably you felt normal for you. Yeah.
When I was talking to her on the phone, I was wondering at that point whether my asthma is bad. So when I get to that point, I give her a ring and wait and see what she says.
Okay, so in terms of knowing whether your asthma is bad or not, so yes, family and friends who know you well and know what you normally sound like and behave like, absolutely really valuable, really valuable. For asthma management, things like your peak flow, sometimes that's a helpful outcome measure. Not for everyone. Sometimes doing peak flows can actually make your asthma worse because you're blowing hard, and like she was saying about lung function being awful for some people, that hard blowing can really set your chest off. So peak flows aren't for everyone. I suppose it's trying to think of ways of working out whether my breathing's worse or not. So when you can time your respiratory rate, so if you're sat on your sofa or your comfortable chair or lying in bed, you can set a time, look at your watch or set a timer for a minute and count how many breaths per minute you're taking when you're nice and relaxed, not when you're just in the throes of a conversation or you've just been shouting at your neighbour for making too much noise or something or something like that. When nice and calm, nice and quiet, what's my breathing rate and what is normal for me? And respiratory rate's a really sensitive indicator. Actually, we use it in the hospital as one of the key things we check, along with blood pressure and pulse and temperature, to give us a clue whether someone's deteriorating or not. So that's a thing you could do in terms of working out, am I worse or not? And in terms of your action plan for your asthma management, that's something you should have. So you talked about frost air and stuff and when to use Ventolin, those kind of things, but that's the conversation to have with your healthcare provider. Okay, which yeah, I can't really tread on their toes on that one, I'm afraid.
No, that's fine. Our surgery doesn't actually have asthma nurses. If you're having a problem, you go and see a GP and he'll just talk to you. But Thank you.
Yeah, and if you want something to prompt the discussion, if you go on Asthma UK's website, I think there's a downloadable asthma action plan document. So if you've got a printer, you can print that out and go, hello, at the moment this is blank. Let's fill it in together so I understand what I'm supposed to do. Yeah. And then you've got some control of that conversation, and you leave with a written plan, rather than you wait for this ethereal document to be dictated to a secretary and then maybe to the GP and then to you, if it's a consultant, which can take a bit of time. That way you'll leave that consultation with a written plan that is in your hands and you understand.
Lovely.
Okay.
All right. Thank you very much. Thank
you.
you.
I got a bit assertive then, didn't I?
Sheila, I will find that plan and I'll drop it into the Facebook group. So I'll pop a link to it in the Facebook group so you know which one Phil's talking about.
Lovely. Thank you.
Okay, and has anybody else got any questions? Oh, Mick?
Just a quick comment, just to say thank you. Excellent discussion. Matches everything I've had at the hospice and the training and the pulmonary rehab, all the physios, lots of useful information and well worth practicing it all. Thank you.
Thanks, Mick. Thanks, Mick. It's good to see you.
Brilliant. And you're getting a thumbs up from Celia there as well, Phil. And a thumbs up from Glenn. Lots of thumbs up. They're all over the screen now. Can't keep up, from Mark and Kay, Helen, Godimal, Gwyneth. Everyone's doing thumbs up. So thank you very much, Phil. That was fantastic and much appreciated. So
absolutely pleasure. Okay, so
we're putting the recording on if anybody wants to watch it back.
Okay, I believe in a couple of weeks you've stitched me up to talk about exercise as well, haven't you? Yeah, so in those 2 weeks, have a little think about what you want to know about or understand better, and then I'll try and make sure I address it with my slides. Because if you don't tell me, I'll just do my normal talk that I've done a million times about exercise and telling you how it's brilliant. And that'll be very boring. So if I can do some specific sort of stuff, that'll be
yoga, because you get the breathing as well.
Don't make me do yoga on camera, man. I'm the least flexible guy in the entire world, but yeah, we can talk about yoga and stuff.
The hospice do it sitting in a chair, but as you do the various arm movements, they time it to your breathing.
Yeah.
You're concentrating on your breathing as well as the exercise.
Yeah. I'm familiar with that kind of technique. Yeah. Okay, cool. We can. I'll talk a bit about that in a couple of weeks. Once I've done, Phil does some furious googling. No, I've seen that used in hospices before, so yeah, I know the technique.
Celia, have you got another question?
Yes, please. Only that, if possible, Phil, when you do your exercise talk, could you cover CPA and bleeding and what exercises are safe to do, please?
Absolutely.
Thank you.
I will do.
Thank you very much.
Okay.
Yeah.
Right, what we'll do is, Phil, is we'll get a thread going on Facebook so we can document all these beforehand, and I'll send it to you in an email.
That'd be amazing. Thank you.
Right, everyone. If that's it from everyone, we'll let Phil go. I'm sure his kids are bashing down the other side of that door if they're anything like mine.
Well, my wife's just taken my father-in-law and the dog to go and get some blood tests, so I've got the kids to myself. But I'm looking forward to my lunch because I haven't had any lunch, so I'm going to have some lunch.
Well, thank you very much, Phil. That was much appreciated, and thank you everyone for joining us.
Yeah,
absolutely, guys. Thanks so much. It's nice to see people, and yeah, thank you.